So this patient's coming in for removal of a large mass he's had growing on his left upper shoulder for quite some time now. So essentially what we've done is a large circumferential block, and we've anesthetized another area along the incision line, which really I don't do because it's necessary. I do to check my block because I'm going to be incising there and to make sure that we have good anesthesia. So this doesn't hurt when I do that?
No.
He said no.
Okay, and this is the challenge that we'll have with doing larger procedures in the office. It's always the anesthetic. In theory, we just have to dissect down, take this lipoma out, and that won't be the big complication. It's going to be whether we can have good anesthesia or not. So where I'll be worried about it is towards the ends, we'll have to be watching it, but especially underneath. So as we get to the back end of this, we'll have to make sure that we have good anesthesia. Maybe we have to add a little bit in, but we'll see how we do with things. So I'm actually working with a Dr. John today. We haven't had Dr. John in a while. We usually have Dr. Janes, to be quite honest. So this, remember which number blade this is?
That's 15.
Number 15 blade. And what do we use for the anesthetic?
Lidocaine.
Lidocaine.
With epinephrine.
With epinephrine. And what's the toxic dose without epinephrine?
Without epinephrine is 5. It's 5.
Yeah, 5 milligrams per
7.
kilogram.
Yeah.
And then what is it with?
7.
7 milligrams per kilogram. And why the difference? Why is it more with
Why
epinephrine?
is it more with that? Because of the vasoconstricting. So
yeah, that's the main
slower.
issue. Yeah, and the secondary issue, the toxic effect of lidocaine is what?
Like it's essentially like.
What organ systems does it affect?
What organ system?
Yeah.
Is it hepatotoxic?
No, it's digested from a hepatic perspective,
okay.
but it's the toxicity is cardiac.
Cardiac.
So this is why when you're also infusing with epinephrine, you're offsetting some of that. But the main reason is what you're alluding to, which is the epinephrine constricts the absorption, so that's why there's the ability to put in more. So essentially what we're doing here is we want to cut down to the actual hypodermis and then dissect this down. So as opposed to a cyst where I'd be going a lot more slowly and gently because we were worried about rupturing the capsule, here I'm not overly worried about the capsule. Now there is a capsule on lipomas, but it's much thinner. You're still comfortable?
تحس بشيء؟
No.
No.
اللدر.
بس شوية؟
ايه.
He said just a little bit.
So that's hurting?
أذيك كلش؟
No.
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 Okay, let me know, because anything other than just pressure I want to know about. So here what we're seeing is the hypodermis and the dermis can be quite thick. So we're just getting down to it now. Let me check this out. And see how that's released now? See the difference in width? So why the difference? Why is this so wide and this one's not? What's still intact on this side? Do you have that for me, please?
What's still intact here?
Yeah, why isn't this gaping like the other side is?
Like the
Obviously I haven't cut as deep, but what's keeping it together? What's the layer that keeps that together?
fascial. Well, there's no fascia because it's a muscle, but
You're thinking of it. It's the dermis.
Right.
So the dermis is still intact. So that's the difference in terms of the layers and what they do. So the epidermis is essentially just water tightening the skin. That's its purpose more than anything else. Obviously, to fight off some infections and those type of things and penetrating it. But the strength layer of the skin is the dermis. So when you're through the dermis, you see it sort of release. And what we're seeing here is that dermis is very thick. So you can see here, so now we're through that.
okay. Do you feel like a release of pressure, tension,
Yeah, you can feel when you go through it, it'll just sort of open back up for you.
and then you're in subcutaneous fat?
Yeah, then you're into the hypodermis.
In his case, lipoma.
Yeah, so no, the lipoma is distinct, so you'll still have a hypodermis. So you're still going to deal with an area of tissue that's sort of fatty, but not quite the lipoma. And you can usually differentiate between the two. Sometimes it's difficult. He's still feeling okay?
Yeah, okay.
Good.
حدان زينة؟
Yeah. بعد بنجي ده يضربه؟
لا لا دي شبكة.
Okay.
So essentially I just want to join these two incisions, then I'll dissect that down once I get there. So this is all hypodermis.
That's still hypodermis that you're kind
Yeah.
of just entering? Is this just because you've done so many of them, you have the experience to know the
Yeah, you'll recognize. So we might be flirting with the
lipomas?
lipoma on this side.
Capsule.
So we'll, yeah. So once I get this down a little bit. And this is always the frustration with dealing with the upper back and the lower back. Like just the tissue layers are so thick. Just dab that for me, please.
And you're using pickups?
Yep, just the Adson's ones, so the ones that actually have the teeth on them.
Right.
Because if you don't, you can't. Just dab that for me. Let's see where that's looking more friable. That's more like the top of the actual lipoma.
Getting flashbacks to anatomy lab now.
Mm-hmm.
Through dissecting. So you're under hypodermis.
Yes. So now we're kind of within the hypodermis,
Within.
but this is the lipoma that we're dissecting out. So and how long do we have to do this? So what's our half-life? How quickly does lidocaine work?
How quickly does it work?
Yeah.
3 to 5 minutes.
Yeah, generally talk about it should kick in most people. I'm going to shift here for you.
Mm-hmm.
Within 30 seconds, but generally they'll talk about 4 minutes as being the time frame where you're like, you should have good anesthesia within that time frame. And then how long does it last? So see how that's different there?
Hours, but like I would say 4 hours maybe max.
Yeah, that's what you're looking at. So generally in that area. So usually if you have somebody who goes through it quickly, and everybody will be a little bit different in terms of how they absorb it, you're looking at a minimum time of half an hour, and then on the upper end, you're looking at about 4 hours.
4 hours.
And so what's its half-life, if that's the case?
What's the
Assuming you can divide 4 by 2, which I'm going to give you the benefit, you're going to be able to...
Let me just run a few numbers.
Just give you a second.
Okay.
Yeah. So about an hour and a half to 2 hours. You're good?
Yeah.
Yeah, good. Yep, down that front, please.
So do you, when you dissect, are you
Yeah.
going to kind of try and get this outlined that you mark? Or
Yes, that's what I'm denoting. Just add that for me, please. That's what I'm denoting as my distance, because this is where I'm feeling the edge of it is. So this side, hopefully we can get to that aspect better. So I'm just feeling where I'm at and what that feels like underneath. This side feels actually better.
Just trying to release as much as you can? Or?
Yeah, break down adhesions and sort of see what I have to do more work with. You're okay there?
Yeah. Da, da.
So see how that's just adhesion there?
It feels good?
That's adhesion above the actual lipoma. So
That
that's
is?
like hypodermis. Yeah.
Okay.
So what I'll do with that.
Well, and what would happen if if there's a little adhesion that you missed? Would it just not come out cleanly?
Yeah, and sometimes lipomas, unlike cysts, where you'll see a lot of cysts where we dissect that out and it comes out entirely intact. Lipomas can be a bit more of a challenge that way, because on the underside they can adhere to the muscle layer, and you can also get them to the rest of the hypodermis. They can adhere a little bit too. Now see, I'll have you put your finger. Just feel right in here for me. It's okay. See how you can feel around it? So you feel underneath that?
Yeah.
Yeah, you feel
the
distinct
angle,
mass? Yeah. That's what I want to be dissecting. So this is why
It's a lot
I'm,
more firm than I thought it was going to be.
but this is what we want. So if I'm dissecting this properly, Brad, just give me a, what I want to be breaking down is those adhesions so that we can just pop this out.
You just pull it out.
Once we break down enough of it, I can feel there's still some I have to dissect down through this side. You're okay?
Yeah?
تحس بشي؟
No.
So this is the spot where I just want to be careful from the standpoint that you're not feeling anything.
Because of how deep it is.
Yeah, because I'm in around behind it. But much like cysts, see how that's the soft tissue?
Mm-hmm.
That's what I want to be dissecting down
Yeah.
over.
No.
ها؟
لا.
And I want to release it from that. So you just want to see what you're doing. This is why it's hard for you to see from that angle.
Yeah.
Just dab it for me.
I can kind of see through the camera.
Yeah. So all I'm wanting to see is what I'm doing. Dab it for me, please. So you see how that's all fibrous? See that?
Mhm.
That's what the membrane looks like in a lipoma. See the back end?
Yeah.
That's what you're cutting through.
But that right there is just like subcutaneous fat.
Yes, that's just adhesions. See, that's a good look of it right there.
Yeah.
See that? That's all the back end of where the lipoma is just strung out and connecting with subcutaneous tissue.
Okay. So if you miss a little piece of lipoma and there was like a little pop, would it just grow back?
Generally, yeah. So this is why you want to try to be as thorough as you can in terms of dissecting that out. You felt that? Yeah, we're almost done. But see,
حسيت
that's
بشي باب؟
Hey.
Yeah, he's feeling a little bit pain.
yeah, yeah. So this is where I'll.
نزلتني
So
هواية؟
this is always the area where I want to be a little bit careful.
ها؟
I did.
Not from a dangerous perspective, but just because it's the big one like this, obviously. We're so far behind, you know, the block we did.
Right.
Yeah, you're almost there. You okay?
Yeah.
Do you have to have IV supplies to do this, or do you just keep it in the office too?
Yeah.
Just in case.
Yeah.
Okay.
It's not hurting when I do that.
تحس بوجع؟
No.
And that is it.
Was it tricky?
So you can feel how firm that is? And that's where it's different from normal fatty tissue. Like it's
Yeah.
quite firm. So
Yeah,
this
it's
is
like
why you
rubber.
know you took out, and this is why it's referred to as a tumor, even though it's a benign tumor. But you can see how big that is. So when you look at how underneath the skin, so even though this will look like a big incision, when you think about that we took out that big a mass, it's not that bad at all.
No.
So, and now we just have to put this back together. So what we want to do now is, I always syringe these out. So I'm going to first and foremost.
Do you ever rupture them just to look, or is it just?
Oh, you can if you want. Here, we'll grab a. Can you grab me a scalpel, Rada? Because we'll have to do this anyway to fit this in. So what would we expect? Should it be the same throughout? Should there be something inside it?
It should be the same throughout.
It should be the same throughout. Right? This should be all lipomatous tissue. So it's shifting on me a little bit. And that's what we'll get all the way through it.
And you have to cut it in half to get in this specimen container.
Yeah, she'll have to cut this up anyway. So, but you should see all the way down. This should be all just lipoma, and that's what that is, all the way through, just like that.
Right.
Yeah.
Okay.
What are all?
So it's like a small liposuction procedure.
Yeah, that's what that's for. But the sad thing is, and this is what different systems are the same. So why do this in this setting? You know, why not send them all to general surgery?
No.
One is because, you know, if you can do it locally, can you just grab me the bifurcator? So here again, remember I told you there's different types of pain, so I want to make sure that he's not feeling that too much. Is that hurting?
بتأذيك؟
No, no.
No.
So it's really the back wall that we want to be touching up. These ones on the side, like we're going to be doing dermal stitches here. Yeah, felt that one? Yeah, a little more freezing. So this is all behind the circumferential block that we did, so. Okay. And you could see at one point, this was right above this muscle there at one point. So I'm going to stick away from that side. I'm just going to see if I can deal with some of the stuff over here.
Right above his trapezius?
Yeah. And that's what you get into when you have these deeper ones.
I'm gonna hold that up.
Yeah, if you don't mind.
Are you gonna suture what's bleeding off?
Yeah, so just if it's bleeding really briskly, like through here, I'm just gonna put in a stitch here. There we go. Just cut that for me. So any brisk bleeds, I just want to tie them off.
Be notre étroit.
So see how that's not bleeding the same?
Yeah.
You want to go over here and check this same thing out here. So the big area that we want to watch is this posterior area, just to make sure there's one there.
In terms of bleed, hemostasis?
Yeah, exactly, because we're going to get these edge areas. See how that's stopped completely now?
Mhm.
These edge areas we're going to get with our dermal stitches. So as long as it's not oozing from here, see like this area, like I'll touch them up, but I don't really need to. And you do want some degree of a bit of a moist bed, because that just encourages healing. So just put this here for me. Now, where this is generally more important is if I'm doing, not that it's absolutely critical, let's say we're doing an infected field, ruptured cyst, and it doesn't come out intact, and we certainly want to be cleaning that out. This, it's not as critical. I generally do it just as a point of habit. It's never a bad idea to irrigate. Looks pretty good. Awfully clean. Very clean.
Yep.
Right.
How many people minimum would you do this with?
Say that again?
2 people minimum for this?
Yeah, that's where you'll certainly want to make sure that you have some assistance with that part. So here, the closer, so you go from deep to superficial, and then essentially you want to be at the same spot on the other side, and also go to the same depth. So like if I was to make this one tighter than I did on the other side, that's not a good thing.
Right.
If you're going to be loose on one side, be loose on the other, because you just want them to come together appropriately.
Can you just come out through the bottom of the wound? Like, can you go superficial to out of the wound? Or you want to go through the bottom of the deep, on the deep aspect of the suture?
Here, give me 1 sec. Let me tie this off, then I'll... So say that again?
So, like, could you go superficial to out of the wound? Like to deep?
Like to the skin, you mean, or the...
No, so when you're going through the dermal wound, so
Yeah.
you go through the superficial, could you go up and down through the bottom of the dermis, like right here?
So you mean as opposed to going deep to superficial, you mean do the other way, superficial to deep?
Superficial deep.
Oh yeah, you can. So the only difference here is, so if I start here, so if I'm starting here, let me see where I'm at. And I'm finishing superficial, but on the other side,
You're
I'm
gonna-
going superficial to deep.
Okay.
Where's my knot?
Yeah, I mean, that's...
Where is it?
Well, it's going to be deep.
It's going to be deep, right? So my point being is you can do it the other way, but your knot's going to be more superficial, and generally you don't want the knot to be superficial.
Okay.
So would you be wrong in doing it? You can do it, but then you may have the knot sticking out a little bit of this, then you'd have to make sure, unless where you're doing it is a little bit deeper from the epidermal dermal junction. And if that was the case, then maybe you'd get away with it. That's the risky run.
With gut?
Yeah, unfortunately, it goes. So if I'm a little bit more pressure on it, then I'll lose it. Probably gonna need another one. So.
Mhm.
Which isn't a big deal. I mean, if you lose through it. So the tighter I am to the epidermal dermal junction, then the tighter this will come together. But I'm not worried about that cosmetically, because here it's just serving as the strength layer.
Mm-hmm.
My superficial stitches are what's going to actually bring that together. Let's see, rotate on me. Pull it together. So there's always a balance. You want to sort of put tension on it, but not too much tension. Trying to do it on this side.
Have you ever like made an initial elliptical incision and then realized you have too much? You still have too much redundant skin?
Oh yeah, you can. You can always adjust that. Generally, no, I would say.
You just cut out more skin.
Yeah, and same thing with let's say we were doing where you sometimes have to make that adjustment is if you're doing like smaller lesions, and because it's so small, it's so tight. When you're using your scalpel, you fray the edge.
Mm-hmm.
You know, you cut it a little bit. That's not, especially if you're working solo, you'll do that because you don't have anybody who can pull this together for you. So all you do in that case is you just clip the edge, make it clean. So in how many of these you add, just more becomes a function of how much assistance you think you'll need or how much tension across the actual incision.
If you didn't put any dermal stitches in,
Yeah.
would it heal?
Yeah, it'll heal. It's just more likely that afterwards, like if he's difficult with it, like depending on, and difficult's not so much always a choice. Let's say a manual laborer, somebody who works out in his yard a lot, like those type of things.
You okay?
Ja, oké.
Has a sheet?
No, no.
You can open that back up a lot easier.
Right.
I've only ever seen one time in my career where, and it goes to show you where you can still, did I untie that? Or even with dermal stitches in place, the patient tore through them. This is what it's always, the complications I've ever had with incisions are all young males,
We are
Yeah.
interesting breed.
Yeah. Well, and it's always ones like they just, they'll come back and they're like, but it was my,
Jet ski. It was really
yeah,
fun.
it was bench press day, and I was like, okay, could you not have backed off just for the 1 week? And that's what happened. Yeah. You should be flattered. She's looking at you. You're in good enough shape. She's thinking maybe he does bench press every once in a while. Yeah. But anyway, that's the thing you'll have to sort of emphasize with them, because you can have a beautiful, surgical procedure and a beautiful result, and then it's all compromised because they don't take care of it from a wound care perspective.
Mhm.
Then it's just, all of that stuff is just lost.
In that case, you have to remove like what is left of the sutures and then just re-suture it.
Yeah, so there's been cases where I have to, so let's say it dehisces. So whether I do that from somebody else's procedure or one of mine that opened back up, like again, that's happened, even in those cases, that's only happened like a handful of times at most in 25 years. You just have to scrape the edges off so you re-expose the basement membrane, and then you have to re-stitch it closed. So now you can see, so here this one's tighter to the epidermal junction. These ones are a bit looser, but that's okay. I'm not worried about that. You can see how much that's closed with the
Yeah,
dermal
yeah.
stitches. Let's put pressure here for me. Just gonna take this out.
Is this 5-0 prolapse?
This is 4-0.
Well,
At an area like this, I would never not have dermal stitches, just because the failure rates would be, or dehiscent rates would be high, and you don't want that. So I do tell the patient, this will relate through to his son, like the dermal stitches, some people will feel those. So, weeks after it's gone, if you feel like some swelling underneath the tissues, that's the dermal stitch, and that'll dissolve slowly over weeks. if you're lucky, months. So it has some strength behind it long after you've taken the superficial stitches out.
Right.
So here we want to make sure that the basement membranes are aligning. That's the most important thing here. So you sometimes see me push down on it. I'm just trying to make sure that one side lines up with the other. So when you do the downside of an elliptical incision, even though I would have done that every single time here because it was so big, but the downside is, you know, are you going to make this come together anatomically just like it was before? Because if my elliptical incision was slightly off on the one side, you'll create some asymmetry. So you want to make sure that these basement membranes are lining up. So I'll slow this down. Go back, please. Go back, please. Thank you. So here when I'm slowing this down, so I'm putting this in, even though it looks like I'm putting it like this, it's always perpendicular.
Mm-hmm.
You're driving it in because tough skin won't pierce it properly otherwise.
Does he have thick skin?
A little bit. So here's my V here. I do 3 loops so it locks. I grab the tail and it should sit like that. See how this? See if I do it this way? It's not
like
even.
knotted?
Yeah. So and you don't want that because it won't be even.
Right.
And now I want the one side base membrane to line up with the other. So sometimes when I push this down, it's just so that that lines up a bit better. So you don't get any buckling and this will heal properly. So in generally on most spots other than the face, plastics will talk about being about 7 millimeters apart, you know, for stitches. That's not a number that's actually written down in manuals, but most of them follow that pattern. But depending on where you're at, if you want to then have more strength or you're taking them out quicker, you'll just adjust that.
No.
I was always told that if you have more stitches for face, less scar.
Yeah, that's generally the case because you're taking them out sooner. So you would put in more stitches to have them tighter together, but then you would take them out. Whereas this, like this, I'll have in for close to 2 weeks because it's such
really?
because it's such a big area and there's so much tension in the upper back. But the face, I take them out in 4 days. You know, so typically, much like you've seen me do with other ones, I'll take out every other one just to see how strong it is. Now at 2 weeks, it's going to be strong enough that won't be an issue. But if I was dealing with a facial laceration and we'd only have them in for 4 days, I'll take out every other one, and then if it's strong enough, then I'll take out the rest. And usually it is, because you want to get them out, because that's where people always assume that train tracking is just because you use stitches in the first place, because you're seeing the incision points, but it's more because they were left in for too long.
Oh, okay.
Do you have the cartridge, right?
Yes.
So I'm just gonna do a couple more, then I'll have you do the last one.
Sure.
If you're comfortable, you're okay with that?
Oh, yeah, for sure.
I know you've done lots of stitches, but when you're
Yeah.
videotaping it, it's...
The world will judge.
That's why you're Dr. John. So.
Nice name.
Any complaints you come up with?
Yeah, Dr. John. You're still comfortable?
The one's in?
Yeah, it's okay.
Yeah?
It's good, yeah.
It's okay, thank you, brother.
So what about post-op pain meds? What do you think in this case?
I mean, Tylenol and ibuprofen should be good.
I would say so
Could
for...
give them Tylenol 3.
Yeah, for most lesions, I would tell you, like when we take out cysts, usually have minimal discomfort, if anything. But this was because it's so deep and how thick it was. I'm going to give him some pain medication, because whereas most will just be like a deep, you know, ache, he may have a little bit more discomfort.
Right.
And what about antibiotics? Do we need antibiotics?
Not prophylactically.
No, we don't do it prophylactically. There's certain cases where you will. So where I'll sort of wimp out more than anything else, like if this was the base of his neck, you know, really deep close to his spine, those are ones where you're just like, maybe I'll just, but there's no real reason. That's more a function of, the face is another one, because if it got infected, you'd be like, oh, this is a disaster.
Right.
You want pickups?
Sure. I don't usually use them all the time, but
Yeah, it's your choice.
what I was gonna say. Yeah, he does have thick skin.
Sure. Yeah, that's what I'm saying. So you have to drive in. Yeah, you're good. You got through. But that's why you want to drive in at 90 degrees. So you'll very quickly change that angle. But initially, that's what you want to do.
So I just want to visualize this. So that is
Yeah.
right this way. He goes right this way.
Here.
This way.
Yeah, that way. See there.
Yeah.
Perfect.
Kind of wasted a lot of it for you there.
That's okay. I'm paying for it, so.
Yeah,
What do you care?
it comes out of my budget.
But this is something as you're doing more procedures, you'll just waste less of that.
Yeah. Okay, so you're saying drive in at 90 like this?
Yeah, so you want to drive in at 90 because especially he's not bad. I would tell you he's medium, but that allows. And as soon as you puncture, once you see you go through, then you can choose to pull it back and change your direction, right?
Right, I see.
But you'll be through the actual. And what's the layer that's inhibiting you there? What's giving you so much resistance?
For me,
No, but what tissue layer? We talked about it before. What's
epidermis?
It's the dermis, right?
The dermis.
Yeah, because that's the layer behind it that's
Oh, okay.
providing all the strength. So you can usually get through the epidermis, but then it's. No, it's the other way. Yeah. There you go.
I guess when you do enough, you get like the
Yeah, you'll feel it as you're pulling it
muscle
through.
memory.
And just one more. Almost done. Last one.
Here, I can do this. I'm just holding on now. Yeah, that is a lot easier.
Yeah. Otherwise, you'll just struggle. You're almost there.
I was gonna back up just a bit.
That's okay. We'll pull the stitches. Yeah.
Good. Yeah, there you go. And you saved it, which is good. You have to get up a new pack. That's nicely done. So this looks pretty good, nice and aligned. So we're just going to clean this up. You can see how that divoting, because we took out such a mass,
Yeah.
but that will sort of balance itself out. Subcutaneous tissues will adjust over the course of the next, 6 months or so. So essentially what Rad is doing there is what I do afterwards. So anytime you catch your thread, don't worry about it, but just after the fact, you'd go through
Oh,
and you'd
okay.
separate. See, here's one here.
Yeah.
You would just pull it out. So don't worry about that while you're doing your procedure, because you'll just take time you don't need. Just at the end of it, you'll go along and you'll clear those up. She'll put a dressing on that, then we'll see him back in about 10 to 14 days.